This Week in Richmond is made possible in part by Dignity Memorial, caring for our communities with a network of funeral homes and cemeteries in Virginia and throughout North America. More information about Dignity Memorial's providers is online at dignitymemorial.com. The Virginia Chamber of Commerce, the voice of the Virginia business community, working in legislative, regulatory, and political arenas to promote the free enterprise system. Information at vachamber.com. Virginia hospitals and health systems provide jobs. They support our economy and promote public health. Local hospitals are always open to help people with unexpected health needs. Having a stable healthcare network is vital. Virginia hospitals are our lifeline.
It's amazing what my students with special needs can accomplish. Their pride is priceless. That's why I teach.
Brought to you by the Virginia Education Association, because a good education is good for everybody.
Additional support is provided by these sponsors. And by the members of Virginia's public television stations. Thank you.
Welcome to This Week in Richmond, and a very special welcome back to Dr. William Hazel, or as around Capitol Square and other places, it's Dr. Bill.
Thank you.
Secretary of Health and Human Resources. And as we were talking just moments ago, there's much to talk about, but to tell our viewers, we're talking on Monday right after you've been in Southwest Virginia.
That's right.
And have just gotten back, so why don't we start with that issue of remote medical services that are provided in WISE.
Right. Well, I just got back Saturday from the Remote Area Medical Clinic, also known as the RAM Clinic,
Yes.
which is at the WISE Fairgrounds. And this is the 7th year that I've been out there. And so once a year at this particular clinic, several thousand people come. They get dental care, medical care, and it is really the only opportunity for most of these folks. Now, it's interesting. In past years, we used to see people from Kentucky for medical care. We're not seeing them now.
I know where you're going.
Yeah, they
Yes.
expanded Medicaid over there, so
Yes.
we don't see as many now. What is interesting is some of these folks still that come for dental care, but really for the medical care, the Medicaid expansion there seems to have taken that population. But people come in on Thursday night, they camp out. I think we had about 1,300 went through on Friday. I don't know the final numbers yet for this year.
Yes, yes. Well, and one of the reports I was reading about it said that even some maybe who've gotten on the Obamacare, as it's called, still had other medical needs that were not being covered, and so some of them were there too, whether it was for eyes or for.
In Medicaid does not necessarily pay for vision coverage,
Yes.
and it doesn't necessarily pay for dental coverage.
Now,
So
dental
those
probably was-
people would
yeah.
still come for vision and medical.
Yeah, and the dental, that was the one I think it was mentioned
Yeah.
was really the big one, and some moving stories that have been in the media about someone who'd been suffering with intense pain for some time but couldn't afford to
Right.
have anything done.
It's amazing, and we don't think in medicine, at least when I trained, we didn't really think that much about dental being part of it, but yet dental is a big piece. People come to the emergency room with jaw pain. I know from being in Martinsville a couple of years ago, they talked about the need to have dental work done there because of people would come in and guess what they're prescribed? Opiates. Which leads us to another problem we're having, of course, which is just the number of opiates that are out on the street right now.
Yeah, well, before we leave that RAM clinic, I want to make an editorial comment and then get your reaction. And friends in Southwest Virginia know that I have roots. I know Norton,
Yep.
I know WISE, I know Big Stone Gap and East Stone Gap. But to me, it's sad. It's almost like the way medical care would be delivered in a third world country where doctors are going over and nurses and other healthcare providers. And I think my editorial comment, Dr. Bill, is that it's a sad commentary on the Commonwealth that's how health care would be delivered. It's great that people volunteer.
It is, but it's not adequate.
No.
I've done surgery in Bolivia,
Yes.
and I can tell you that being out there in Wise, seeing these patients in orthopedics, and this is say 7 years I've done this. We're in a tent. A couple years we were in a stable at an fairground, an exhibition stable. Is not ideal. It's crazy to think that we are the world's wealthiest country and we have this problem.
Yes. Yes.
It really is.
And probably there are other pockets in the Commonwealth, any number of them, that could almost duplicate that if.
Well, I know the Dental Association has their Missions of Mercy, their mom clinics, and they have them in Southside, and I know they've had them out in Northern Neck and other places. So it's not unique. This just happens to be a really big one.
Right, right. Well, now, you were moving into the problems in many parts of the state, but also significantly in Southwest Virginia with opiates. Tell us more about that.
Well, the hard fact here is that for the last several years, more Virginians have died from opiate overdoses than from motor vehicle accidents. And it's a bit of a moving target, and it is different in different parts of the state. In some parts of the state, the problem was heroin, and now it's more potent heroin or heroin laced with fentanyl, which is another prescription medicine that can be knocked off and made in labs. Then in some parts of the states, it's just pills. And in Southwest Virginia, the problem is still really the pills. And going back to the late 1990s, medicine began to take a different tack towards pain management, and it became accepted to provide opiates for chronic pain. And I think we were encouraged as physicians to be more aggressive with pain management. We were taught that pain is the fifth vital signs. There's the pulse and the blood pressure. There's the respiratory rate and the temperature are four vital signs, and pain became the fifth vital sign. So we were encouraged to check regularly. We were encouraged to prescribe, and of course with patient satisfaction, nothing makes anybody unhappier than to go out without their pain medication. And what has happened over time is that there are just too many pills on the street, and the folks from the high-intensity drug trafficking areas will tell you that there are too many pills out there. So what we have found out is that people can get addicted. I was told in practice, the drug reps would come in and they say, if you take this for pain and after surgery, you won't get addicted. Well, that's just not true. And so we end up with getting pills after surgery, and maybe too many, and sometimes the individuals who are taking a legal medication with the prescription can begin to develop addictions. We see some where there are leftover pills in the medicine cabinet, and we hear of kids having pill parties on Friday night where they're swapping pills. I know that there's some barter economy in Southwest Virginia where people swap pills for goods. So it's a real problem. It's a real problem.
We maybe talked about former Delegate Jackie Stump previously, but if we didn't, he was here in the House of Delegates, I think, prior to your coming to Richmond. Right. And I could still see him practically almost crying on the floor of the House to try to convince his colleagues to pass some legislation that would require some reporting, the pharmacies and all to do some reporting, so people wouldn't be doing doctor shopping.
Well, we have that. It's called the Prescription Monitoring Program.
Yes, and I think he really helped get some of that done here in the Commonwealth, at least by law, to get that done, to try to, at that time, to cut down on the problem almost a decade ago.
Well, you'd be amazed when we look at the data, the number of people who go to 10 or 15 doctors and pharmacists and get the pills. So we have that, and in the last couple of years there's been some legislation that basically automatically signs up all physicians, that requires physicians to check the prescription monitoring program when there's a prescription for more than 14 days. There is some reporting capacity we have now We have passed some laws requiring the Board of Medicine to draft some guidelines, or actually regulations really, for physicians to require continuing medical education upon certain prescribing thresholds. So we are working a lot in that area, but I think there are really probably 5 pieces to this, David, that we've got to deal with. And number one is harm reduction. Until we have to recognize that people who are currently addicted are either in recovery or they're not. And these people will be with us for a long time, we hope. And so until they can get treatment and things, we have naloxone, which is now available at a lot of pharmacies, where you can go in and just get the naloxone by a standing order, so that no questions asked. You pay for it, you get the naloxone, you learn how to use it, and that is a medication that can reverse the effects of opiates for someone who overdoses. And it saves lives. Within the first few weeks of the Virginia Beach Police having this, they had saved a number of lives. And I asked the chief, I said, "Chief, so what do you do?" He said, "Well, we take them to the hospital." And so the system has to pick those up. But we have prevention of death. The next piece is, and we've seen in other states and a little bit in Southwest Virginia, where the sharing of needles has led to hepatitis, and there is a concern about HIV, so that's a risk. Another risk is the babies that are born to pregnant women who are using drugs. And these babies have neonatal abstinence syndrome, and instead of going home from the hospital within a day or so, they go through withdrawal. They're there for extended periods of time, and these children could have significant lifelong problems, and it's a real shame. We were talking about Judge Hurley down in Tazewell, in his drug court. He now is, I would call him the godfather of 13 babies born drug-free through his drug court. And so it's powerful, powerful work. Then the fourth thing that's harm reduction that we need to think about is this drug epidemic we're having right now is probably the leading cause of foster care. Children coming into the system where the public now has to be responsible for them. And we really do need to look at the children of these people who are addicted, because that's the next generation that's likely to have trouble. So these are all things that are out there. So harm reduction first. Then there's got to be treatment. If we have these people and they are with us, how do you get back to being functioning in life, employable? And so we really need to think about making treatment available. That we did get a substance use disorder waiver through the General Assembly this year through Medicaid, but when that comes online next year, it'll only help about 10% of the people who need it, because the other 90% aren't eligible for Medicaid.
Right.
So we have that problem. Peer engagement is important, and we're developing some criteria for peer engagement and treatment. Getting guidelines around medical assisted treatment. Suboxone is a medicine that people use to help reduce the cravings when they're in recovery. And the challenge is when used appropriately with counseling and so forth, it works really well. But the key to medically assisted treatment is the assist.
Yes.
So just the prescribing of Suboxone, then you get a substitute medicine, when we now know there's a market in that. So that's something we're going to be working on, and I think taking a look at it for this year. So the treatment is out there. The third piece of this is reducing the supply of pills. I talked about this continuing medical education for physicians, use of the prescription monitoring program. We've really got to stay on top of this and get the number of pills off the street. The fourth issue then is heroin. In some areas of the state, heroin is more available. In some places, because you could still get pills, they don't switch to heroin. So Upper Valley, Winchester, they've got a program. They're dealing with really a heroin problem there. So we got to continue to chase the bad guys. And that means the big distributors, the people who are pushing this poison. And I think the fifth area that we have to address is really cultural. Number one, pain does not always require narcotics. There are other things, and as we've learned more about the science, there are alternatives to narcotics. There's a lot of good work in that area. Number two, we've got to address the issue of stigma around treating addiction and getting people back to work and so forth. If you have been addicted and you look at it as a medical problem where the brain has been hijacked, whatever got you into it, it may have just been taking medications after surgery, which were legal and prescribed, that got you into it. Your brain's hijacked. And you're acting in ways that you would not act otherwise. And once you're in treatment, we need you to work. We need you to be back productive, taking care of your family and have a job, which means we have to open up employment to these people and so forth. So these are some of the really big things that we have to think about. And then the final thing is, for kids, safe and legal aren't the same thing. And there's things you just shouldn't put in your body.
Yeah. Well, each of those ones that you enumerated, and hopefully people out there were taking some notes, that are things that ordinary citizens can do in the process. And to go back to one of them, because it's been a while since I've recalled hearing anything here in metropolitan Richmond, but I know that times there have been indications if there are extra pills left over,
get rid of them.
Bring them. I mean, even almost like people willing to turn in guns. There have been programs, I think, where people could turn in pills because, am I right or wrong or correct it for our viewers?
Well,
I've heard you aren't even supposed to flush them down into the water.
Prefer not to do that.
Yes, okay.
Prefer not to do that. But there are take-backs, and a lot of the law enforcement offices have take-backs. Some of the pharmacies do. And my hope is that will become more available. But that is part of getting the pills off the street. Many times you go to the dentist for work and you get a prescription and you don't use all the pills. The thing to do is get rid of them as soon as you can. Just don't have them there.
Right.
And I think that would help a lot.
So probably we would maybe say check with your pharmacist almost the first place.
Yes, that would be a good place to go.
Most of them, and hopefully soon all of them, would take back those and destroy them properly.
My hope is that every pharmacist will have a little note on the bag saying, this is where you take your unused prescription. Please get rid of it. That would be my hope.
Oh, that's a good program for some of the ones to pick up.
If a pharmacist is listening out there, please.
Right. Yes. Or those of us who from time to time get prescriptions, we will encourage our pharmacists to say you should have that on there.
Right.
Because I'm fortunate that I rarely have a prescription, but if it's for a pain, I maybe one day I'm through with it, and I guess I've been known to have something stay in the medicine cabinet far longer than it should.
I think we all tend to. Things just kind of build up, but get rid of that stuff.
And because those pill parties are not limited to any one particular part of the Commonwealth. We hear them wherever that kids get a hold of those. And crazy.
Yeah,
really
so
crazy.
It's a tough problem, and it's going to be with us. So it's real important, I think, that we do look at this as long term. And again, the folks who are addicted, we hope will have a full and healthy life in recovery. And that's really where we need and be productive. It means we've all got to rethink our attitudes about this a bit.
Switch over to mental health initiatives, because there's some major work that's been going on and going on right now, and some mental health issues here in the Commonwealth.
Right. There is a lot going on, and I think probably from where I sit and what I've learned over the last 6.5 years is that, in a very real terms, David, I can't say that we have a real system for treating mental health in the public sector. And I'll say that for a couple reasons, but the first thing here is that we have community services boards. And let me preface this by a lot of good people doing the right thing under what I would consider pretty extraordinarily difficult circumstances related to resource availability. That's one thing. But and as they have gone from being general fund funded agencies to having to do Medicaid to get their resources, most private sector folks say we can't even survive on Medicaid, much less save enough to do all the things you aren't required to do. And the only thing that CSBs, or two things that CSBs are required to do, is assessment for temporary detention orders to determine individuals at risk to himself or others, and before we deprive them of their rights and hospitalize them. That's one. And the other is some case management. So anything else the Community Service Board does is dependent on their ability to acquire the resources to do it. Now, we have a lot of programs. Let's say that the General Assembly says we're going to have 5 crisis stabilizations. There'll be a competition for that. So the more resource-rich community services boards are better able to compete for those. So this, unfortunately, is a case where the rich tend to get a little richer and the poor tend to get a little poorer. And we end up then without a complete system around the state. That's problem one. Problem two, which has come highlighted recently, is that the community services, such as they are, don't necessarily carry over into the jail system, right? And there's even a more difficult part when an individual is referred from the jail to the hospital for a mental health treatment, evaluation, restoration, whatever. Let's say that somebody from Fairfax is sent to Western State and they're evaluated and they're put on medication. There is a chance when they go back to Fairfax that the medication will change because the formulary is different. So why did we do that? So our lack of organization and coordination and the resources to manage this don't exist. They just don't exist. The Department of Behavioral Health and Developmental Services does not have jurisdiction over jails. The community service boards are out there. There are 40 of them. Some are county agencies. Richmond is an authority. Some are multi-counties. If you take out the $110 million a year that Fairfax and Falls Church add in local funding to that CSB, and you look at the rest, the localities really don't have the resources to put into it. So we can talk around this a lot, but until we make the commitment that there will be a basic level of services, and that services should be there the day you need them. If you are addicted and you decide that today is the day, an appointment 2 weeks or 3 weeks from now doesn't help you. If you are in crisis, when we invest in crisis, which is what we've done, crisis response, crisis stabilization, hospitals, if you invest in crisis and don't invest in prevention, then all we have are crises. And people in crises get picked up by the police and they go to jail because there's no place else, no service in the community. And these people shouldn't be in jail to begin with, for the most part.
You know, practically every disaster that we hear about where someone has used a weapon, a gun for the most part, to kill innocent people, there's some indication that there was some mental illness and something that had gone untreated. And as you and I were talking before we started the show,
I want to push back a little bit because there are different things, and being mentally ill and being dangerous and homicidal are not even remotely the same thing. I just get that. Yes, there are people who are mentally ill that have created crimes, but some of these big episodes that we've been reading about recently are in the name of terrorism or something else that have nothing to do with mental illness. And I just don't want everybody to be thinking that mental illness is causing this Orlando shooting or the one in California. That's not it. But yes, I think mental illness does need to be detected and treated earlier.
Yeah. And certainly I did not want to imply, I will correct myself.
Yeah, I just want to be careful.
I don't want to imply that people who are mentally ill are likely to be the ones doing this, because even when mental illness is involved, it's maybe a fraction of 1% of all the people who are suffering some mental illness. Before our time is up, we wanted to talk some too about the change in the number of people who are homeless in the Commonwealth.
That is a good news story.
Yeah. We'll end with good news.
Right. Governor just announced last week our point-in-time counts. And let me preface by that, like once a year in the winter around the state, there's a count of people who are homeless. And the agencies that deal with this, what we call the continuums of care, go out and find these people. Since 2010, we're down over 30% in our point-in-time count numbers, and that's an additional, in the last year, about 10%. Plus, we have housed over 2,200 veterans, making us the first state to functionally end veteran homelessness.
Yeah, that part has been mentioned before about the functionally ending, but you're saying all homelessness.
Right, it is family homelessness, severe mental illness. We have a ways to go. Let's be honest about it. people go in and out, so it's not like you solve the problem and it's done. We have to stay at it. But a change in the way we use our resources. A meeting last week we had with the Governor's Council on Homelessness. The people from different agencies that work together with an aligned purpose it's been rewarding.
Dr. Bill, thank you again so much for being on This Week in Richmond. Encourage our viewers to watch the show more than once to get those 5 issues that you talked about.
Thank you.
Thank you.
I appreciate it.
Thank you.
This Week in Richmond is made possible in part by Dignity Memorial, caring for our communities with a network of funeral homes and cemeteries in Virginia and throughout North America. More information about Dignity Memorial's providers is online at dignitymemorial.com. The Virginia Chamber of Commerce, the voice of the Virginia business community. For jobs, the economy, and public health, Virginia Hospitals, our lifeline.
The Virginia Education Association, because a good education is good for everybody.
Additional support is provided by these sponsors. And by the members of Virginia's public television stations. Thank you.